This video on surgical infections is the first part of a three-part video series. First, we need to understand that the host, or the human body, has its own defense systems against the bacteria. The intact epithelium acts as a barrier, in addition to which the skin has its own commensals, and these commensals will block the attachment and the invasion of the non-commensal organisms. The epithelial cells get shed, and also the sweat and sebaceous secretions will prevent the overgrowth of the non-commensals. But when there is a breach in the barrier function of the epithelium, or if there is lack of secretion of sebaceous secretions, which happens in a case of an open diabetic wound or any ulcer, when there is maceration of the skin, this is when there is going to be an overgrowth of non-commensals, or sometimes the commensals get a little too virulent, and these cause the wounds or the infection in the wounds. The usual organisms that one sees on the skin are staph and strep. One can also see Corynebacterium and Propionibacterium. These are the usual organisms which infect wounds, and especially diabetic foot also. In the infraumbilical areas, in addition to these organisms already mentioned, one can also see E. coli, Enterococcus, Enterobacterium, and Candida. It's interesting to note that eczema and dermatitis are caused by an overgrowth of commensals coupled with a breach in the barrier function. Moving on to the respiratory tract, the respiratory tract has mucus which traps both particles and microbes, and the mucus is either cleared by coughing, and if it's very small particles, it undergoes phagocytosis. Most of the other body tissues, including other tracts such as urogenital tracts, biliary tracts, pancreatic duct, and distal respiratory tracts, are usually sterile. When there is an infection of the biliary tract, the gastrointestinal tract, the pancreatic duct, most of the time, and even in the urinary tract, most of the time these are gram-negative organisms, which can either be, or most of the time they are gram-positive anaerobes. The GI tract has its own commensals. The colon has anaerobes, mainly bacteroids, Bifidobacterium, Clostridium, and Fusobacterium. There are also aerobes such as E. coli, Enterobacterium, and Enterococcus. Usually, once the microbes enter a sterile body compartment or a tissue, either by a perforation or an injury, that is when the additional host defenses will start acting either to limit or eliminate these pathogens. For example, if there was a perforation, the initial host defense is the physical barrier of the tissue itself, for example, the mucous membrane or the subcutaneous or the submucosal tissues. Lactoferrin and transferrin, they sequester iron, which is very important to the microbial growth. Now, this also is a host mechanism. Fibrin, which is like the superglue present everywhere, will act to form adhesions, and it also acts to wall off the inflammation in an abscess, so it also traps the microbes. In the abdominal cavity, the mechanical pumping action of the diaphragm moves fluid into the thoracic lymph channels, therefore trying to localize the infection by the omentum, by the stasis of the bowel to form an abscess, and also trying to form some degree of a subphrenic abscess by taking all the fluid to one direction. Thus, the Rutherford-Morrison pouch is one of the most dependent areas in the peritoneal cavity. Contributing to this at the microscopic level are the inflammatory cells and the cytokines. Now it's very important to understand that the body tries to eradicate the infection either by containment with the formation of pus, or it tries to form a loco-regional infection. So the ultimate end of an infection is either complete eradication by the body, formation of a pus pocket. If it gets worse, it could be a loco-regional infection, and the worst case scenario is a systemic infection with sepsis. Taking the background of what we had discussed earlier in the other videos about inflammation and hemostasis and shock, you would realize that if there is a systemic inflammatory response syndrome originating either by trauma, aspiration pneumonia, pancreatitis, myocardial infarction, burns, head injury, or even infection, the general variables are usually fever, which is either hyperthermia or hypothermia, tachycardia, tachypnea, and either leukocytosis or leukopenia. There are many other variables which could occur in SIRS. Hyperglycemia, which basically reflects a hyperglycemic state, or there could be an accumulative balance with an altered mental status, more amount of banded forms seen in the blood smear, again increased levels of C-reactive protein and procalcitonin, both of which are pentaxetrins. There could be a lot of hemodynamic instability in the form of decreased systolic blood pressure, decreased mean arterial pressure. Also, there could be many organ dysfunction variables such as hypoxia, oliguria, rise of creatinine, coagulation anomalies, and hyperbilirubinemia. Therefore, if the SIRS is caused because of infection, then the spectrum will move forwards. So, if there is SIRS with the documented infection, for example, you get a wound swab or a gram stain, which is positive, then SIRS with the documented infection is called sepsis. In the likely event the sepsis is severe and the SIRS gets worse, and there is going to be organ dysfunction or hypoperfusion, this is called severe sepsis. You can easily say this because your ABGs get worse, there is more amount of lactate and base deficit. At the same time, you will have organ dysfunction, which means to say there could be IDS, patient needs ventilation because of type 1 or type 2 respiratory failure. The heart doesn't work so well, so the BP goes down and there is tachycardia. At the same time, you remember there could even be vasodilatory type of shock. And basically the whole metabolism of every individual organ doesn't perform so well. So you could have the kidneys also not functioning so well, altered mental status, and all this is part of it. If supposing there is severe sepsis, along with which there is refractory hypotension and hypoperfusion, this is septic shock. And failure of one or two of the organs, along with this, is MODS or multiple organ dysfunction syndrome. This is the mnemonic that I usually use to remember common pathogens in the surgical patients. There are two activities going on. One is an aerobic activity and the second is an anaerobic activity. As you can imagine, in both sides, aerobic and anaerobic, there is a good thing happening and a bad thing happening, or a hero and a villain, as you can imagine. Now, a cool sister, a cool sister as you can call her, is going jogging, and that's an aerobic activity. So she is positive, it's aerobic. So SES stands for Staphylococcus, Streptococcus, Enterococcus. So these are the gram-positive aerobes. So the cool sister, she keeps his saxophone. So she does something negative when she's jogging. So these are the gram-negative aerobes. So that stands for Klebsiella, E. coli, Enterobacter, Proteus, Pseudomonas, Haemophilus, Serraceae, Acinetobacter, and Xanthomonas. Whereas the anaerobic activity that's taking place is between two chaps. The positive guy, the police constable, who is a nice guy, standing for Peptostreptococcus, and the C is Clostridium species. And the negative guys, the anaerobes, are the Fusobacterium and the bacteroids, the boyfriend. So the boyfriend is the negative guy in the anaerobic environment, maybe waiting there in a phone booth, and the undercover cop, the PC, police constable, is the positive guy who is also hiding. Now, as far as the fungi are concerned, it's pretty simple to remember. Candida, coccidioids, and Cryptococcus or coccidioids. Whereas it's very rare to see Histoplasma, Mucor, and Rhizopus. Aspergillus also. So these are the fungi which are seen in skin and soft tissue infections, usually seen in immunocompromised patients, especially when you catch something like Rhizopus, Mucor, Blastomyces, Aspergillus, etc. The viruses, I mean, they are too common, so there's no mnemonic to remember them. And the various other bacteria that one can get are Nocardia, Legionella, Listeria, and Mycobacterium. Hope that helps. Just to remind you, these are the common organisms isolated from the hands of ICU personnel. Either Staphylococcus, which is the gram-positive, the gram-negative are the Serraceae, Pseudomonas, Enterococci, Acinetobacter, and Klebsiella. And Candida is a very common fungus isolated from the hands. Now this shows you that hand hygiene is very essential, because in the likely event that hand hygiene is not done, these common commensals can actually get onto the immunocompromised host and cause havoc. So it's very necessary that you spend at least a few moments of hand hygiene prior to handling your patients, and also remember the 5 moments of hand hygiene. Thus, as we noted earlier, the various spectra of microbes that can cause infection, now we try to understand this a bit more deeply. When one takes a gram stain, one is trying to identify if it's gram positive or gram negative. One works also on the morphology of the bacteria to see if it's a cocci or a bacilli, etc. The culture and sensitivity will then try to culture and grow the organisms, at the same time try to see which are the antibiotics that can inhibit this growth in vitro. One should understand that the common commensals, that is the gram-positive aerobes that we had spoke, sister, that is Staphylococcus, Streptococcus, usually they cause skin and soft tissue infections and may also cause cholangitis. But in the likely event that there is any foreign body, for example, an intravenous catheter, it could be a central venous line, or even an indwelling catheter, urinary tract, these can infect these foreign bodies and devices, and they can also cause catheter-related sepsis, necrotizing fasciitis. So one must be aware that these organisms can cause a lot of trouble. Most of the time the UTIs are caused by the Streptococcus, and even the blood-borne infections are caused by Streptococcus. On the other hand, the Clostridium species are known to cause cellulitis, gas gangrene, and Clostridium difficile causes antibiotic-associated diarrhea. Propionibacterium is another major species. It is usually a skin commensal, and also it is an infectious manifestation of acne. So as noted previously, blah blah. The fungi, on the other hand, are identified by special stains such as potassium hydroxide, India ink, silver, or Giemsa. Usually the fungi are rarely seen, but they can cause infections as part of a polymicrobial infection. So they can be super infections. At the same time, they are very rarely seen in skin and soft tissue infections such as mucor, rhizopus, etc. The viruses are usually difficult to culture, and they are usually identified by indirect means, that is the host antibody response. But nowadays, recently they use the polymerase chain reaction to check for the presence of bacterial DNA or RNA. So therefore, the relevant viral infections that one sees are usually in the immunocompromised patient. The general idea for the prevention of surgical infections is taking good technique of prophylaxis. For example, hand washing, scrubbing preoperatively, prepping the patient's skin, and clipping as opposed to using a razor. All these can actually reduce the dose of the inoculum and can prevent the infection. When it comes to using prophylaxis, mechanical methods, chemical methods, or a combination of all of these are equally effective. When one uses an antimicrobial agent as a prophylactic agent, one will choose the agent based on the tract that one is entering. For example, if it's mainly to do with a skin procedure, one would bother about the commensals of the skin, which is mainly the gram-positive aerobes. In the likely event one opens a biliary tract or the intestinal tract, one would take care of both the skin organisms and also gram-negative organisms, which may be commensals in the GI tract and are potential commensals or potential infective agents of the biliary tract. When one deals with the colon, one would think of the skin organisms and also the anaerobes, which are gram-negative. For example, the bacteroids and the fusobacterium. So it all depends on which organ one is going into, the approach that one is going through, and what you would feel that you're dealing with. This is how you choose your prophylactic antibiotic. Also, don't forget that you should check for allergies, and you should check your local hospital as to what organisms you usually catch. One should remember that the source control is an important method for the treatment of a surgical infection. It could mean the drainage of purulent material, putting an interventional radiology guided drain. It could be the debridement of tissues, removal of foreign bodies, aggressive debridement when it comes to necrotizing fasciitis, even amputations if supposing it calls for it. Rarely do antibiotics work without doing a proper source control. Empiric therapy for use of antibiotics can be started when it's a high-risk patient or a high-risk case, and you start the antibiotic therapy based on the underlying infectious process. Usually the empiric therapy is for a short duration, and you stop it when there is a culture and sensitivity result, and then you will start the base treatment based on your CNS. But remember that the clinical course of the disease is also something which one should look for. If your empiric therapy is working and you see that the patient is improving clinically, then go ahead and continue with that. One should also consider that the infections could be of two varieties. The polymicrobial infections are usually seen when there are abscesses or a very large wound, for example a bed sore or a chronic wound, and one needs to do a good source control and then add the antibiotics while dealing with these infections. Remember that just because it is polymicrobial doesn't mean that every organism should be attacked. There is one organism which predominates and the rest of them are just contaminants. But if this leading organism is taken care of, that's when the contaminants can either become overactive or be completely taken off the area. The monomicrobial infections are usually nosocomial infections seen in immunocompromised patients or post-operative patients. For example, UTI, pneumonia, bacteremia. These are usually monomicrobial. The patients will have SRS, either with a positive chest X-ray or a gram stain, and they can be started initially empirically on a broad spectrum antibiotic and then slowly de-escalate based on the culture and sensitivity. The antibiotic therapy again depends on the kind of infection that one is having. It could be antibiotic therapy for 3 to 5 days for a UTI, 7 to 10 days for a pneumonia, and up to 14 days for a bacteremia. A surgical site infection could be a superficial surgical site infection, which involves only the skin and the subcutaneous tissues. A deep SSI involves the fascia and the muscle up to the peritoneum, whereas an organ SSI or a space SSI involves a preformed anatomical space, for example the pleural space or the peritoneal space or the interloop spaces. An organ infection, as one can understand, is a deep infection, just like a space infection. Now, a surgical site infection can be thought of as an abscess. As you all know, the abscess is defined as a collection of pus lined by an inflammatory granulation tissue. If you have an abscess in a preformed anatomical cavity, for example, a maxillary sinus or the gallbladder or the pleura or the peritoneum, that's when you call it an empyema. Now, it so happens that the surgical site infections are related to certain factors. First of all, the degree of microbial inoculation. Second of all, the duration of the procedure. And third of all, the host factors. Now, depending upon the type of surgeries that one is doing, you could classify your wounds as a clean wound, that is called class 1. For example, if you're going into a procedure like thyroid or breast, in these procedures one doesn't open any tract, you're dealing with only skin organisms, and the expected infection rate is about 1 to 2%. A clean contaminated surgery or a wound class 2 is one in which you enter a tract or a hollow viscus, but there is no contamination and there is no spillage, so there is a controlled entry. For example, one is doing a lap chole without spillage, or one is doing an end-to-end anastomosis without spillage. It's a good example of a clean contaminated, or else class 2. The infection rate here can be anywhere between 2% to 10%. Usually one doesn't include colorectal surgeries here. The clean contaminated cases and the contaminated cases, for example, in which there is a major break in technique or there has been uncontrolled spillage when one opens a tract, or if one is doing a lap chole and there is spillage of bile, these cases are considered to be class 3. Here the infection rate is anywhere between 3% to up to 14%. Therefore, they used to say that if you are dealing with a patient with a class 1 or class 2 wound, you can actually go ahead and do the closure. Whereas if you are dealing with somebody with a class 3 or class 4, class 3, as you all know, has been explained. Class 4 means there is a wound which is dirty from the start. The presence of bacteria is there even before you operate. For example, perforated case with peritonitis, or there is somebody with an abscess or a complicated fistula. Here you are dealing with a dirty wound. So in class 3 and class 4, the infection rates can be anywhere from 3 to 15%. And if you close the skin primarily, there is a 25 to 50% chance that one would definitely develop a surgical site infection. But with the use of antibiotics, you can reduce the rate up to 4%. Now, there are various patient-related factors which can promote or give a high risk for wound infection. Elderly people, those with endocrine disorders such as those who are having diabetes which are poorly controlled, immunosuppression, chronic kidney disease, peripheral vascular arterial disease, anemia, radiation, chronic skin disease, which both render the skin a little less than perfect, recent surgeries that could have been done in the same area, if there is malnutrition or smoking or a very chronic inflammatory process. These are patient-related factors. The local factors of the wound could be a very prolonged operation, an open operation as opposed to a laparoscopic procedure, very poor or careless skin preparation, instruments getting contaminated, if supposing the antibiotic prophylaxis has not been given, too much of tissue destruction or too much of tissue necrosis, blood transfusions, and one factor which can be under the control of the surgeon and the anesthetist is hypoxia and hypothermia, because it has been shown that hypothermia and hypoxia during surgery are associated with a higher rate of surgical site infections. The microbial factors depend upon the inoculum of the bacteria, also prolonged hospitalization promoting nosocomial infections, the toxins secreted by the bacteria, and the resistance that the body fails to provide, thus increasing the bacterial resistance to the clearance of these particular organisms. Thanks for watching. Like, comment, subscribe, email me.